Hi, I'm Cindy Rapp from Denver, Colorado. Today we're going to be talking about sonography of non-simple breast cyst and color Doppler. Non-simple breast cyst and color Doppler in breast sonography. We have been taught that with our improved resolution, cysts that appear to be simple on some of our older equipment actually appear to have internal echoes on the higher resolution equipment that we scan. Now, the problem is that we have been taught that any cyst with internal echoes should be classified as a complex cyst, and we've also been taught that most complex cysts are something that are worrisome. And scanning breast cysts, sometimes we'll see things that look like this, where you have one cyst that is almost simple, but if you notice there's a little bit of internal debris. Sitting right next to it is a lesion that almost appears to be solid. Nice through transmission, similar to the other cyst. No matter how we turn the transducer, it remains round. So I know one trick that a lot of us want to do, just take our gain, turn it down, just to make sure that we clear out the echoes and make these cysts look more simple. But one thing we want to make sure when we are doing breast imaging is to always keep fat at medium gray. If we have black fat, we can actually make solid lesions appear that they're cystic. So we really need to retrain our brain in looking at these types of lesions. Now, some cysts that we see in breast sonography have almost what look like a solid and cystic component to them. These we refer to as an acorn cyst. And there are cysts that appear as solid as a fibroadenoma. These we will call foam cysts. They're also referred to as a gel cyst or an inspissated cyst. We'll also see cysts that have internal echoes. And if you do something that increases the intensity of the beam, such as turning up your output power or turning on color or pulse Doppler, you can actually get these echoes to start moving in there. Now, non-simple breast cysts, they are so common. We take this pathology specimen, invert the image of it. They occur way too common for us to biopsy any of these or even aspirate them. If we were doing that, we would be following up every cyst or aspirating every cyst that comes through the department. We need more of a rational approach on how to evaluate non-simple breast cysts with sonography. Now, the percentage of cysts that are complicated is increasing. One reason is we're using higher frequency transducers than we did in the past. We have broadband technology, and we're using a higher dynamic range than we used to. So also what we're noticing is real echoes produce internal structures, and there's also some artifact that we'll see. If we look at a TDLU, the terminal ductal lobular unit, these are where cysts and also solid nodules arise. So you can see the different changes. If you have a normal TDLU, you can go through some cystic degeneration. The cysts start to enlarge, break through the walls of the cyst, and eventually will form one fairly large tension cyst. If you rotate your transducer on the long axis where you can see the duct coming in, we have a better idea that these are actually cysts that we're dealing with, or cystic change, rather than true lesions. So here we can see ultrasounds of a normal TDLU. Here's one that we've gone through some cystic change or some microcysts of the TDLU. You can see the cysts have gone to a little bit larger, all the way up to a tension cyst. These are the same lesions, but just rotating around and finding the normal extralobular terminal duct that goes into the TDLU makes you much more confident that you're actually dealing with a cystic lesion or cystic change of the TDLU. So if we look at our strict criteria, if we're going to call something a BI-RADS2, it needs to be completely anechoic, well circumscribed, thinly encapsulated with enhanced through transmission, and a lot of times we'll see thin edge shadows. Now, things like compounding and harmonics will help with these if you look at the ones with the asterisks behind them. But compounding may actually decrease through transmission and thin edge shadows if you're using that. However, these are features that can be turned on and off while you're scanning if you still like to be able to see the thin edge shadows and the enhanced through transmission. So here's an example of what is a strict criteria for a BI-RADS2, a normal simple cyst, and it would be wonderful if we would see simple cysts like this all the time, but so many of the cysts we see with sonography do have internal echoes. General rules about non-simple breast cysts: the vast majority of non-simple breast cysts are within the spectrum of fibrocystic change. Malignant cysts are something that are exceedingly rare, And usually if there is a malignant cyst, it's going to be obviously malignant. There will be features that you're going to notice that will say this is something that definitely needs to be biopsied. In individual cases, general rules are not necessarily reassuring, so we really need a systematic approach on how to evaluate cysts in the breast, similar to what we do with solid nodules. So we look at non-simple breast cysts in lesion 2, our systematic approach. The first thing we want to try and do, eliminate artifacts. So we want to take what's complex and indeterminate, try to make it a simple. If we can't eliminate the artifact or what appears to be an artifact, what we're going to do is search for the worrisome features. So anything that would be considered a BI-RADS 4 or 5 are the findings that we're going to be looking for. If we don't find any of the BI-RADS 4 or 5 features, then what we want to try and do is identify it as a BI-RADS 2 classification. If we cannot do that, then what we do is try and move it into a BI-RADS 3, which is a probably benign classification. If we cannot classify it as BI-RADS 3, then we will consider it to be a BI-RADS 4 classification. This is basically the same thing that we use when we look at solid nodules. First thing you want to do is start looking for the most severe type of things, such as our 4s and 5s on BI-RADS, and then try and prove that it is completely benign. And if you can't, classify it as something that is indeterminate. If we look at the types of things that cause echoes within these cysts, we have protein globs, cholesterol crystals, fat globules, white and red cells, epithelial cells, foamy macrophagia, apricot cells, papillary apricot metaplasia. Solid structures that we can see within these are also papillomas and carcinomas. Now, if you aspirate breast cysts, the fluid that comes out isn't just a clear serous fluid. These were all just examples of aspirations from different breast cysts. If we video invert those, you can see the different echogenicities that we'll see within this fluid. And now you kind of have an understanding as why we see the echoes that we do in the breast cysts when we're scanning. Now, each of these here, what we have is a pathology. Then we video inverted the pathology and have an ultrasound exam. You can see this is a nice thin echogenic wall of a simple cyst. This is where we sort of have a fatty buildup on the inside wall of a cyst. This is a single layer of apricot metaplasia that we'll see, one layer within this cyst wall. And when you have papillary apricot metaplasia, you can also have what sort of appears to be a solid nodule within it, but this is papillary apricot metaplasia, which is just part of the spectrum of fibrocystic change. Looking at our complicated cysts, our simplified rule for a BI-RADS 3, identify those for solid nodules. So what we're looking for is something round or oval. We're looking for thinly encapsulated, and we use color Doppler to check and see if there are any fibrovascular stock. Once again, for seeing the thinly encapsulated, using features such as harmonics and compound imaging can be very helpful in looking at that. The artifactual echoes, we'll notice with our increased frequency and increased bandwidth and dynamic range, we can have reverberations within cyst, we can get clutter, ring down, we'll have volume averaging, and actually some speckle that we'll see within them. So the first thing we want to try and do, eliminate artifacts within these cysts. As I mentioned earlier, coded harmonics and real-time compounding can be things that will help to eliminate these artifactual echoes. So if we look at this ultrasound image, this is a cyst that was scanned just with normal fundamental imaging. You can see all the internal echoes that we see within this. We've got, edge shadows coming off of it, nice through transmission. By turning on harmonics, we cleared out a lot of those artifactual echoes. You can still see the nice through transmission and the edge shadows. So we were able to partially clear out some of the internal noise just by using harmonics on this particular cyst. Here's another example of a breast cyst that we can see some internal noise on. This one is slightly lobulated, and you can just see that the TDLU can go through these lobulated changes. By using compounding, this is taking the beam and steering it in from the sides. You can see how much of the artifact has been eliminated. Also notice that we can see the wall of the cyst, nice thin echogenic wall, much better. But the other thing to note, the enhanced through transmission that we see so well on the image on the left, you don't see quite as well with the image on the right, and that is something that we are aware of when we use compound imaging. Now, if you have a cyst that has real internal echoes, and when you use something such as harmonics, you'll see that the echoes actually increase when you have real echoes in there. So the image on the left was done in fundamental imaging. image on the right was using harmonics, and now it appears that there are more echoes inside. We still have the normal sound transmission and edge shadows that we'd expect to see from the cyst. So first thing we try to do was eliminate artifactual echoes. Now we're going to use a systematic approach. So next we're going to look for any features that might be worrisome that you would classify as a BI-RADS 4 or 5. Anything that's given a BI-RADS 4 or 5 is typically recommended for a biopsy. So the things that we're going to look for are thick isoechoic septations, any type of a mural nodule. We also use color Doppler to look for the presence of a fibrovascular stalk, and we're going to look at clustered microcysts. So the image on the left, this we would just consider to be simple cysts. It's basically one simple cyst up against another one. These are just sort of a cluster of cysts sitting together. These we would not be concerned about. But when you have a thick isoechoic septation in between cysts, it still could be fibrocystic change, but this is something that we typically would classify at least as a BI-RADS 4A, and these we would recommend for a biopsy. So the features that we look for, if we're going to classify something as BI-RADS 4 or 5, we look for angular margins where the solid portion attaches to the wall. We look for loss of the capsule, also at the attachment to the wall. We sort of draw an imaginary circle around the lesion, and if there's anything that protrudes beyond that circle, that is going to be abnormal. We'll use color Doppler to see if there's presence of any type of a fibrovascular stalk, and we'll also roll the patient up to see if moving them will change the position of what appears to be the solid lesion. Now, most mural nodules that we see within these non-simple breast cysts are actually caused by papillary apricot metaplasia. When you look at this cyst, it looks just like a solid mural nodule. If you use color Doppler, you typically will not see any flow. And this was aspirated, and it was just proven to be papillary apricot metaplasia that you see quite often in a lot of these cysts. Only a small percentage of mural nodules are caused by papillomas or papillary carcinomas. So if you notice this lesion, we can see that it's microlobulated. If we look at the attachment to the wall, there's a little bit of extension coming out through here, so most likely this is going to be where the duct is coming in. But as I mentioned, only a small percentage of what appear to be mural nodules are caused by these solid nodules. If we look at the growth of an intracystic papilloma, they start within the ductal system. As they start to grow and spread, you can see how they will obstruct the neck of this, and then a cyst basically will form around that. So if we actually draw our imaginary line, you'll see that there's extension coming down the area where the duct is at. And here's just an example. This is growth of an intracystic papilloma that we can see the mural nodule. This is the cyst that has formed around it. Here is our papilloma, and you can see that we actually see it coming down through the ductal system and branching out. So growth of an intracystic papilloma. Now on these cysts that appear to be half cystic and half solid, what we want to do is look for any type of an angular margin or loss of a capsule where the attachment is of the solid looking portion. So if you notice, we have a nice thin echogenic line completely surrounding this particular lesion. This is reassuring that we're not dealing with a solid lesion inside of here. If we look at this lesion, you can see that there's extension beyond where the imaginary line should be. This is something that is more suspicious, and this turned out to be an intracystic papillary carcinoma. So once again, looking for any type of protrusion beyond the wall of the cyst, you can see that it's very well confined within this. This is reassuring. And here we have another lesion. Not only that, but if we notice, we don't have a thin echogenic wall. We do have some irregularity, some angular margins, protrusion beyond where the wall should be. This is something, once again, that is suspicious, and this is recommended for a biopsy. The other thing we're going to check for are fibrovascular stalks. So with papillary apricot metaplasia, rarely will you see any fibrovascular stalk. With your intracystic papillomas or carcinomas, typically we will see fibrovascular stalks. Now, one thing is, anytime you're looking for the presence of blood flow in the breast, you need to make sure that you scan with very light pressure. Just the weight of your hand compressing on the transducer is enough to temporarily ablate the flow. So you do want to make sure you scan with light pressure if you're looking for blood flow. One problem with these intracystic papillary lesions, they can infarct frequently. So just because you do not see flow within the lesion does not necessarily mean that you're dealing with papillary apricot metaplasia. Here we can see an example of a complicated cyst or non-simple cyst with what appears to be a solid lesion. There is no fibrovascular flow. This did turn out to be just papillary apical metaplasia. Here on this side, you can see we definitely have a fibrovascular stalk, so we know that this is not papillary apical metaplasia, and this was an intracystic papilloma. Now, in using color Doppler, we find it more reassuring when we have a single vessel feeding into these lesions rather than multiple vessels. One thing we found that with multiple vessels, these tend to be more worrisome, and actually this is a intracystic carcinoma. This was an intracystic papillary lesion. You can also get complicated cysts with what appear to be a mural nodule, and just like what we do for patients with sludge in the gallbladder, we'll roll them up on their sides. We do the same thing with these non-simple breast cysts, and you can see that we just have some sludge inside of this cyst that when we rolled the patient up changed position, so we felt comfortable this is not a mural nodule within this cyst. Now, if we look at the normal TDLU and we look at the mixture of fibrocystic change that it can go through, there are two different paths that it may take. You may have the TDLU go through fibrocystic change where it goes more through a cystic route. If you go through more of a fibrotic route, these look much more worrisome sonographically. And here's just examples of a mixture of fibrocystic change. You can see here we have the normal TDLU. These are going through cystic dilatation of the actual lobule, and the cysts get larger. These, I think, we'd feel much more comfortable on just calling a cluster of microcyst. However, if it takes the route of more fibrosis, you can see why we have much more worrisome, and these lesions typically will get biopsied because they are going to fall more into the BIRADS 4 category, and sometimes we will get back the diagnosis of just fibrosis or fibrocystic change on these types of lesions. Now, if we look at these clustered microcysts, their appearance can be very similar to high nuclear grade DCIS. So one of these is fibrocystic change, one of them is high nuclear grade DCIS. And I'll show you in just a minute which one is which. This was a patient that came in for a breast ultrasound. Indication was a palpable lump. So on her initial ultrasound exam, we can see that there was this 14 millimeter structure. The radiologist who was reading the report that day just called it a cluster of microcyst. The patient actually came back 7 weeks later because she felt that her little cluster of microcysts were enlarging. 7 weeks after her initial ultrasound, it was now 33 millimeters. By the time she went through tumor board and was ready for surgery, 10 weeks had lapsed from her initial ultrasound, and now the lesion was 50 millimeters inside. So this is the one that's a high nuclear grade DCIS. So the images I had showed you before, the fibrocystic change was on the left, and the high nuclear grade DCIS was the image that was on the right. But these can be very rapidly growing. Color Doppler can be helpful because you would probably see the presence of blood flow in looking at these types of lesions. So looking at complex cysts with the internal echoes, we have two main concerns that we're going to be looking at. Either there may be tumor or the patient may have infection. So these are the two things that we're going to look for. Now, for BIRADS 3 signs of inflammation and infection, what we will see is uniform isoechoic wall thickening. You'll notice a fluid debris level, and if we use color Doppler, you'll typically find that there's hyperemia within the cyst wall. Now, sonography cannot distinguish between inflammation and infection by just imaging alone, so these will need to be aspirated, and gram stain and culture is required. But if we look at wall thickening, hyperemia, and fluid debris levels, usually all of these will occur together. This is a patient, we look at the image on the right-hand side. They had a normal breast cyst in the right breast. She presented with left breast pain, and you can see she has this inflamed cyst. Now, a normal simple cyst has a thin echogenic wall. When a cyst becomes inflamed, you can see the wall becomes thick and isoechoic. We have this fluid debris level, and when we use color Doppler, we will see that there's hyperemia in the wall of the inflamed cyst. Typically, you will not see any blood flow in the wall of a normal simple cyst. Now, some differential diagnosis for why we might see uniform isoechoic wall thickening. You can have acute inflammation where the wall becomes very thick. Papillary apical metaplasia, rather than just sort of being one nodule, can actually form around the entire wall of the cyst and have this appearance. And fibrosis, We may have an old cyst that had previous inflammation and now goes through fibrotic change, and so fibrosis can also cause the wall to be thick and isoechoic. The way you can tell the difference is typically if the patient has got fibrosis of the wall of the cyst, they will not be symptomatic. If we use color Doppler, we're not going to see any hyperemia within it. So a lot of times we'll see this fibrosis is just healed stages of the inflammation or a formerly inflamed cyst that will notice this. Another thing that we can see, fluid debris levels. You can see this is a patient that we changed their position and we're able to see this fluid debris level rotate fairly rapidly. So one thing we can be sure to evaluate these is just set the patient upright and see if the lesion does change. Now, some of these complicated cysts with a fluid debris level, it may take up to 5 minutes to get these to shift. A lot of these are a fat fluid level. So here you can see in the supine position, and then as we set the patient up after 2 minutes, you can see after 3 minutes, and then after 5 minutes, we finally get it to go to the dependent portion. So some of these do not change rapidly with motion, but may take up to 5 minutes to notice. One thing that you can do if you think that it might be just a fluid debris level is go in and use Fremitus, and I'll show you examples of this in the later portion of this lecture where we talk about color Doppler, and I'll explain how Fremitus is done. But if this lesion attaches to the wall of the cyst, then when the patient hums, you will notice that the lesion would also fill in with power Doppler. If it's not attached to the wall, you can see that there is no flow when the patient does the humming, but we'll explain more about Fremitus later. This is that same lesion, and you can see by rolling the patient here, you can also prove that it is not attached to the wall. But this took 10 minutes waiting for the fluid debris level to actually shift the non-dependent portion. Now, if you aspirate these inflamed cysts, you can see that sometimes we're going to need the gram stain and culture, but not necessarily cytology in looking at some of these aspirated fluids. Now, looking at these cysts, one way to tell the difference if we have an inflammatory process versus a neoplasm going on is with inflammation, the blood flow will be parallel to the wall of the cyst. If you have a true intracystic lesion, you're going to see that the blood flow will be perpendicular to the wall. So this is a true lesion inside the cyst. This is just inflammation of the cyst. So color Doppler can be helpful for looking at that. Now, looking at this, we're going through our systematic approach. We have tried to clear up any artifacts. We have also looked for any BI-RADS 4 or 5 or BI-RADS 3 findings, which would be infection. Next thing we're going to do is try and prove that this is a BI-RADS 2. Things such as a simple cyst. We can have cholesterol crystals within the cyst. We can have the fat fluid level, milk of calcium. You can get punctate calcifications within walls of cyst. We can see calcified lipid cyst, thinly septated cyst, clusters of macrocyst, and also cysts that arise from a skin. All of these basically would be classified as a BI-RADS 2 finding. So the first thing we're going to look at are cholesterol crystals. These are fairly light particles that we'll see within the cyst. And as I mentioned earlier, if you do something that increases the intensity of the beam, you can actually get these cysts or these particles to start moving. So looking at this image, what I have done is turned up the overall output power. It's not turning up your overall gain, but the output power. And you can see on the cine loop now that we're able to actually get these little crystals to move. These would be classified as a BI-RADS 2. These really do not need to be aspirated. Now, something else you can do is turn on either color or power Doppler, and then you can get what's sort of called color streaking. So these cholesterol particles will start shifting because turning on color power Doppler increase the intensity of the beam. And it's kind of cool because the patient looks over at this and goes, whoa, what's that? It almost looks like the 4th of July when you see these cholesterol crystals with their color streaking. Looking at this ultrasound image, you can see on this loop, it almost looks like we have a mural nodule located in this area. By turning on color Doppler, this just happens to be an artery going over the top. That's not hyperemia within the wall. If you notice here, we have a very thin echogenic cyst. But by turning on color Doppler, we can actually get these particles to start shifting now, so we know it's not a true mural nodule, but there's actually some streaking going through there. So by increasing the intensity of the beam, these are just cholesterol crystals that appear to be clumped together on the first initial image. If you do aspirate these, typically you're going to get more of a greenish gray-brown fibrocystic change fluid. They will typically aspirate completely, and cytology crystals seen on polarized light will have this type of appearance. But most of the time when you get used to looking at these, they really do not need to be aspirated. Now, cysts that contain these fat fluid levels are also BI-RADS2, and as I mentioned earlier, it may take up to 5 minutes to get them to shift. So a lot of times their initial appearance will look like this. 5 minutes afterwards, you can see that we have now shifted. And since this is a fat fluid level, fat will be on the non-dependent portion since it's going to be floating on the top of the cyst. So with the patient supine versus upright, we can see the difference that we will notice on these types of cysts. Also, if we do fremitus, since these do not attach to the wall, we're going to see that the fremitus goes all the way around but does not highlight in the area where it does not attach to the wall. Also, when we roll the patient up, we can see that we eventually got this to shift as another way of proving that it is not attached to the wall. Another thing that we can look at on these fat fluid levels is more of the sigmoid shape that changes. So they start out to be sort of obliquely oriented, and during the process of shifting, you can see that it'll move more into that sigmoid type shape. So if you don't want to wait the 5 minutes for them to shift completely, just sort of watching the shape of it change is one thing. Looking at these acorn or fat fluid level cysts, they are also classified as a BI-RADS2, and they may aspirate completely a lot of times on these, but it's a little bit thicker stuff, so a lot of times you're not certain if it will aspirate completely. Something else that we classify as a BI-RADS2 is when we see milk of calcium inside of a cyst. You can see these two little punctate calcifications, possibly three on the other view when we roll the patient up. Now, to get our classic teacup appearance that we'll see with a mammogram, it typically will take about 15 to 20 stones to get that classic appearance on a mammogram. With ultrasound, we're able to see a single stone, and this was just taking the patient and having them roll onto their side, and we can see that this will actually move with repositioning the patient. So milk of calcium, single milk of calcium in this cyst can be identified with sonography quite easily. You can also have it can be difficult to keep these small cysts sort of in the field of view when you're rotating the patient, but you can see how in moving this patient with a small cyst, you can definitely see there's the milk of calcium moving as the patient is rolling on their side. As mentioned already, the advantage of ultrasound is we can diagnose a single stone on these, and very common for us to see that on ultrasound. If you don't have ability to store your loops, you can take pictures to document on supine, and then documenting by rolling the patient to cubitus that you can see the stone shift, similar to what we would see with gallbladders and gallstones. This was a patient on their mammogram, had multiple calcifications throughout the breast. Taking a cine loop cut, you can notice sort of on this sweep through that every little cyst, we see a tiny little milk of calcium inside the walls of these cysts. So it kind of answered our question on ultrasound. As you can see inside all of this fibrocystic change, almost looks like a Swiss cheese appearance to the breast, that there are milk of calciums located inside the cyst on this patient with the cine loop clip. Now, another thing are circumficial wall calcifications. This is also a BI-RADS2. This is where it's very helpful to look at the mammographic findings, because you will see that the wall is calcified much easier on the mammogram. You know, here, shadowing is something that is worrisome for ultrasound. So a lot of times we wouldn't necessarily know if this is a true tumor or not, but comparing your mammogram, we can see that it's just the wall of the cyst that is calcified causing the shadowing. So always good to compare mammograms and ultrasound when you're making the diagnosis of these. Another thing that will be classified as a BI-RADS2 on mammography and also ultrasound are lipid cysts. Now, they look much more worrisome sonographically. So once again, when you see one of these mammographically, they have a classic appearance. They have the fatty pattern on the mammogram. So you definitely know definitively that on mammography, they are a BI-RADS2, and they are much more benign appearing mammographically than they are sonographically. Microcysts, or cysts that are clustered, you can have microcyst or macrocyst, and with the volume averaging that we get on a lot of these microcysts, a lot of these we will classify as a BI-RADS4A. So it doesn't have a 2% chance or less for being considered a BI-RADS3. So a lot of times these will get 4A. When we have more of the macrocysts, I think we feel much more comfortable in calling these a BI-RADS3, which is a probably benign classification. Now, other cysts that we can evaluate that also fall into the BI-RADS2 classification are sebaceous cysts. They can be completely within the skin. We will notice some that can be partially within the skin, and some of them will appear to be deep to the skin, but the key to diagnosing those is looking for the hair follicle that they arise from. So all of these are cysts that completely arise within the skin. Another thing to notice on each of these in evaluating them, we've used a big glop of gel. Anything that's very close to the skin surface, you will need to use a standoff pad of gel to evaluate these. But here you can see this is completely surrounded by skin. All of these are just sebaceous or epidermal inclusion cysts that we can see within the skin. These also get a BI-RADS2 classification. What make a little tougher is when you have lesions that are partway within the skin and partway within the subcutaneous fat. What we look for to make that diagnosis is the claw sign. So if something is rising from a certain structure, what you'll notice is where it grabs onto it is what we call the claw sign. So where the green arrow is, you can see, is the attachment of where this originates from the skin, and these we will classify as a BI-RADS2. All of these lesions appear to be deep to the skin, but in scanning through, what we're able to notice is the hair follicle that they are coming from. So these sebaceous cysts are just an occluded hair follicle that we can see occurring, and looking for the neck of that is reassuring to know that these are definitely BI-RADS2 findings and really nothing needs to be done further. The other thing to know, our hair follicles do not just arise straight up from the skin, they come in at an angle. So angling your transducer to look for the neck is very helpful and reassuring in looking at these BI-RADS2. So continuing on with our systematic approach, the fourth thing that we're going to look for are BI-RADS3 findings. These types of things would be what we would call our acorn cyst and our foam cyst. So acorn cyst that we can see here is something that we typically will classify as a BI-RADS3 that is probably benign. Indeterminate solid versus cystic, there's subtle differences between solid nodules. This is a fibroadenoma that we can see here. They tend to be more oval shaped, versus what we call a foam cyst, also referred to as a gel or an inspissated cyst. Ecotexture-wise, they can look very similar in evaluating these. So what we're trying to do on dealing with these indeterminate cystic versus solid lesions, once again, try to clear up any internal artifacts, look for internal blood flow. If you can't, assume that it is solid and characterize it as a solid lesion. And the last thing is go ahead and attempt to aspirate it. Now, if we have color Doppler, we can turn color Doppler on and see if there's any blood flow. Just because we do not see blood flow does not necessarily mean this is a cyst, but it is reassuring if you do find blood flow inside one of these lesions, you know you're not dealing with a cyst, that this is truly a solid lesion. So assume solid level 2. What we want to do is usually it has no BI-RADS 4 or 5 findings. BI-RADS3, what we're going to be looking for is round or oval shape, thinly encapsulated with enhanced through transmission. And once again, harmonics and compounding may be helpful for looking at that nice thin border that does surround it. If you attempt to aspirate these lesions, there's 3 possibilities that can happen, and you really can't predict which one is going to happen on one of these foam or gel cysts. They may aspirate completely, you may only get it to partially aspirate, or you might not be able to get it to aspirate at all. So in looking at this, you really can't determine what is going to happen, and the reason is it may be filled with fluid that is very simple to aspirate. You may have some of the fat and papillary apricot metaplasia cells that are within there that you may only get it to partially aspirate, or it may be completely filled with papillary apricot metaplasia that the stuff is just so thick that you cannot aspirate it out through a needle. If you send these for core needle biopsy or vacuum-assisted biopsy, typically on the first or second pass, the lesion will just disappear on you. So here we have one of these that was completely aspirated. We see the needle coming in. This looks like it's a solid nodule, but you can see it completely aspirated and would disappear on ultrasound. Now, if you attempt to aspirate one of these lesions and you cannot get any fluid back, one thing that you can do, if the needle's inside of this lesion, go ahead and try rocking the needle tip internally. If it is one of these foam or gel cysts, you'll be able to move the needle tip from the posterior wall up to the anterior wall. So you can see here on this particular lesion, we've rocked the needle tip anteriorly, so it's on the top of the wall. We went ahead and moved it posteriorly, so even though we weren't able to aspirate it, if we can see the needle tip move inside the lesion, we are much more comfortable that this is a cyst and not a true solid nodule. Whereas if you have a solid nodule and you try rotating or rocking the needle tip, it will stay where it was and you will not get it to move in the anterior and posterior wall. So here you can see this small lesion that looks like a cyst. We put the needle tip in, we attempted to remove it anterior and posteriorly, but it would not rock at all. Now, even though you may have a failed aspiration on some of these, you might be able to look in the cap or in the cork of it and almost have like an FNA that you can evaluate some of these when you try to rock it internally and not able to aspirate any of the stuff that's inside there. Is always check into the cap or the foam that might be in the lesion that you aspirated out. So sometimes we get the papillary apricot metaplasia, sometimes we get the proteinaceous gel within these. So part of our systematic approach, the sixth thing that we're going to do, if we cannot classify it as a BI-RADS 2 or 3, then we do have to classify it at least as a BI-RADS 4A. In looking at the different types of cysts, this was taking one image of a patient with multiple breast cysts. In fact, everywhere you scanned in the breast, you would see cysts or lesions that look just like this. We have ones what appeared to be a fluid debris level. We have ones that appear to be foam or gel cysts. Here we have these acorn cysts. You can see some papillary apricot metaplasia here. All far too many to aspirate these all the time. So in looking at these non-simple breast cysts, the percentages of cysts that are complex is increasing. It's kind of complicated in dealing with these. The gold standard is fuzzy. What we do is use our mammographic and solid nodule algorithm for evaluating these. We use BI-RADS categories. If a BI-RADS 4A, then you need to get histology. If it's an inflamed cyst, you need to aspirate it and also send it for culture. Now we're going to talk about color Doppler, what the role of color Doppler in breast sonography is. We'll use it to try and help us to determine if we're dealing with a solid versus a cystic lesion. We'll look at solid nodules and we can look at the blood flow within it and see if it looks more worrisome for malignancy. We use color Doppler if we're looking at inflammatory processes. And the last thing I'm going to talk about is fremitus, that is done with having the patient hum, and it's done in using power Doppler. So looking at color Doppler, basically it indicates a high metabolic state which is present with both benign and malignant conditions. Highly cellular lesions will tend to get more flow on, also see quite a bit of flow on our inflammatory responses. One thing to remember, color Doppler is very sensitive to pressure. And this is a case I can remember doing back in the early 90s. It was a classic, what appeared to be a fibroadenoma sonographically. In the early 90s, a lot of work was being done, to differentiate benign versus malignant lesions using color Doppler. People were looking at pulsatility index, resistive indices, peak systolic velocities. In scanning this patient, we can see that we have fairly low resistant waveform pattern. We have a peak systolic velocity of around 12 centimeters per second and a resistive index of 45. And when you're scanning, your hand starts to get a little bit tired. And one thing I noticed that as I was scanning, I could compress on this fibroadenoma. I took the peak systolic velocity and cut it in half, took the RI from 45 almost up to 70, pressed down a little bit more and completely ablated the flow. And in doing this, I thought, man, we're onto something here. Here's a benign lesion. By compressing, we're able to shut the flow off. Thought that maybe we figured out finally something that we could use Doppler for to tell benign versus malignant lesions. So the next time we had a cancer, we tried the same thing. Doesn't matter if it's benign or malignant. If you compress, you will ablate the flow. And you say, well, what about power Doppler? Power Doppler is more sensitive than color Doppler. It does not matter if it's color or power Doppler. If you think you have a piece of junk equipment, because every time you've tried to use Doppler for breast imaging and you can never see any blood flow, it may be because you're pressing too hard. So anytime I'm looking for the presence of flow in a lesion, I put extra gel on the skin and lighten my pressure so I'm barely making contact. The other thing I want you to notice are the lesions with the enhanced through transmission are the lesions that we see flow most often through. Your lesions that have intense shadowing, rarely will you see blood flow through those. This is also just looking at an area of high nuclear grade DCIS, and you can see with scanning with light pressure how much blood flow we can see within this area, and then with compression we can completely shut that flow off. So other cystic lesions that we can use color Doppler for. Here's an example of looking at inflammation. This is the same inflamed cyst I showed you before. Typically, we will not see any flow in a normal cyst, but when we have an inflammatory process, you can see there will be hyperemia within the wall. We use it for evaluating solid nodules, so you can see this intracystic papilloma. We can see the vessel that courses perpendicular to the wall, whereas with an inflammatory process, it was parallel to the wall. And just because you, once again, do not see flow does not necessarily mean it's papillary apricot metaplasia, but this was a case of papillary apricot metaplasia. And once again, to tell the difference between inflammation and a true intracystic lesion is looking at the orientation of the blood vessels parallel versus perpendicular to the wall itself. Looking at intraductal papillomas, they also tend to be highly vascular. Color Doppler can be very helpful. A lot of times we can get inspissated secretions, so it may appear to have papillary lesions, but using color Doppler, we typically will find a vascular stalk feeding into the true papilloma. So this is a long axis view of the duct that we can see the papillary lesion. This is rotating the transducer 90 degrees, getting a short axis view. You can see that the blood vessel courses through, so we know it is an intrapapillary lesion. Also, as I mentioned before, seeing multiple branches versus a single branch is more worrisome when we do see multiple branches feeding those lesions. And I've showed you examples of clusters of micro and macro cysts. And one thing you always want to do anytime you see something that is not a simple cyst in the breast is always use color Doppler. Even if you do not see the presence of any blood flow, take a picture that documents that you at least turn color Doppler on. Now this looks like a cluster of macrocysts that I had showed you earlier, or could it be something solid? By using color Doppler, you can see this lights right up like a campfire. We know that this is not a cystic lesion. This was biopsied and proven to be a medullary carcinoma. Other pseudocystic lesions that we can see within the breast, lymphoma can sometimes have this appearance. You can have metaplastic carcinomas. Your high-grade invasive ductal carcinomas will have this appearance, and some of our metastatic lesions. This could almost look like one of the foam cysts, but if we look closely, we notice that this lesion is microlobulated. And using color Doppler, you can see there was quite a bit of flow inside the lesion, a very large vessel that was adjacent to it. This was biopsied and proven to be a metastatic intramammary lymph node. Now this is a patient, 67-year-old female, who had been having her mammograms for years, had always been stable, had pretty much a fatty involuted breast. And one thing that we noticed was she had this lesion that appeared to just pop up on her mammogram. Mammographically, it looked like it was a cyst. And one thing is, you know, someone who's 67 years old should not be having a cyst just pop up on her breast. So we use color Doppler. You can see that there's roaring blood flow inside this. We sent the patient for biopsy. She had this lesion biopsied. It came back as metastasis from a uterine leiomyosarcoma that she had no idea she had. So I always say, put the whole picture together. Even though it may look like a foam cyst, color Doppler was the key to making the diagnosis, to knowing that this was not a cystic lesion. But a lot of your metastatic lesions will be very well circumscribed that we see on ultrasound. Also using it for inflammation. This is a patient with acute lactational mastitis. You can see this inflamed duct right here. In fact, it almost looks like a short axis view of a normal appendix. But you can see all the dilated ducts and looking at this one infected duct. If we turn color Doppler on, here's our infected duct. The wall is thick and isoechoic. And you can just see all the increased blood flow, all the hyperemia within this case of acute lactational mastitis. This is a patient that presented with bloody nipple discharge. She has acute periductal mastitis. Also notice that the wall is very thick and isoechoic. And when you turn color Doppler on, you can see how much, or power Doppler, you can see how much hyperemia we see within the wall of this cyst. And it was the explanation as to why she was having bloody nipple discharge. Also using color Doppler to tell the difference between true lesions inside of the duct versus inflammation. With the inflammation, the blood flow will be around the wall, similar to what we see on cyst, and a true lesion inside, such as a papilloma, you're going to see the blood vessel coursing through the lesion. The last thing I want to talk about is fremitus. Fremitus is done with power Doppler. If you look up in the dictionary, fremitus is a thrill felt by humming. So what you want to have the patient do is hum. A lot of times patients do not like to hum, so you kind of have to hum along with them. One thing I found out, if they have a high-pitched voice, the humming doesn't work very well. They have to have a fairly low voice, hum fairly deep, and you're going to get much better results. If the humming doesn't work, what I'll have them do sometimes is clear their throat, and sometimes that will help a little bit. But this is a case we kind of stumbled on. There's just like a lot of things that you do in your practice. This patient had been called back because they saw a suspicious area on her mammogram. And so she came in, I did her initial ultrasound, took all the pictures, all the measurements. Our radiologist came back in the room to remeasure and take another look and explain to the patient what we'd found. And he was looking for the presence of blood flow inside the lesion with power Doppler. And this lady was someone who was very nervous, so she started asking questions. And one thing we noticed when she started talking was that the lesion, the cancer, never filled in with power Doppler, but as she was talking, all of the area around started filling in with power Doppler. Another thing we noticed is there was an area down here in the breast that would never fill in with power Doppler. So once we re-optimized our image, moved our focal zones down where they should be, we actually found that she had multifocal disease that we had not realized at first. So power Doppler was very helpful in making that diagnosis and the fremitus. Another thing is looking at isoechoic lesions. Here we have this lesion. It could be a fat lobule. It could be a fibroadenoma. We check compressibility. If we're going to call something a fat lobule, we like to see it compress about 30%. We didn't see it compress that much. We went ahead and did fremitus. You can see that the power Doppler fills in on the soft tissue. The lesion did not fill in. This went for biopsy and proven to be a fibroadenoma. So where do we find fremitus helpful? When we look for multifocal disease, when we are trying to evaluate isoechoic lesions, and also with artifactual shadowing. It's not something that I use every day on every single patient that we scan, but there are certain cases that we find it can be very helpful with. This is a multifocal disease on one of the cases I showed you earlier. This is a patient that had diabetic mastopathy, and if you scan many of these patients, you know that their mammograms are extremely dense, and also on ultrasound, a lot of areas of shadowing that no matter how hard you compress, you just can't get to clear out. I'm sure all of us have seen cancers that look even something like this on ultrasound. So in going in and doing fremitus, one thing we noticed that since color Doppler works from the skin down, but fremitus works from the chest wall going up, we completely filled in with fremitus and did not have any void area, so we felt more comfortable that this was due to artifactual shadowing and not actually a true lesion. Looking at this particular lesion, this patient came in with a palpable lump. You can see this small nodule right here. These are what we call one of these barely visible lesions. But in doing fremitus on this small area, what we noticed was this patient also had multifocal disease, and you can see the bridging through the ductal system we can see on this multifocal disease, and fremitus was very helpful in helping make the diagnosis of that. Now, in looking at color Doppler with breast sonography, breast cancer is a spectrum of lesions, and we have found that no single finding is necessarily effective when we evaluate an entire spectrum of lesions. Color Doppler helps identify one part of the cancer spectrum. You know, our sensitivity and specificity are not good enough to necessarily impact the diagnosis or treatment, but color Doppler is probably no better or worse than any other single imaging, and it is something we use all the time in our breast sonography. We don't charge extra. It's just one more tool I have to help make the diagnosis of if the lesion does need to be recommended for biopsy or not. I want to thank you for your attention and hope you have a great day.